the traditional approach with surgery and extensive surgery with axillary dissection was around for 100 years. But it is fraught with toxicity in terms of lymphedema, in terms of range of motion difficulties, in terms of chronic pain. So important strategies have been developed in the last 20 plus years in terms of doing less extensive surgery, such as sentinel node biopsy, and focusing particularly on those who have node positive disease. Then de-escalation criteria will be based on what the initial approach to that patient's therapy is. If a person is treated with surgery up front, then perhaps the de-escalation will be based on commonly known as Z11 criteria. Less than 3 positive nodes, no extranodal extension. The original trial looked only at breast conservation candidates and patients who received breast conservation. But I believe practically we have extended that to patients treated with mastectomy as well. At the other end of the spectrum, patients treated with neoadjuvant chemotherapy, then I think de-escalation criteria would be, number one is that they have a response to the neoadjuvant therapy. Number two is that we have a successful strategy to identify those originally positive nodes, either by targeting them specifically with a clip and ultrasound localization, or by having a good number of sentinel nodes that allows us to have accurate representation of the axilla. So its response is appropriate technique in the number of lymph nodes and accurate identification of the lymph nodes. And finally, it's knowing that being able to select the patients who need axillary dissection is not a failure, but rather is just targeting the therapy appropriately.